Myasthenia gravis. This is a rare autoimmune disorder affecting the myoneural junction. I repeat, it's extremely rare. In fact, in the last 2 years, I've only seen one patient with myasthenia gravis admitted. It doesn't mean there's not many out there. There are people there living with myasthenia gravis, but they're living relatively normal lives. Okay, but again, it's really rare. Look, between 9 and 30 in 1 million people. That's not a lot at all. Yeah. So therefore, if you get this type of autoimmune disorder, you're special. Okay? More often in women again, second and third decade of life, so between 20 and 30. But it catches up to men after 50. Okay, all right. So don't feel that bad. So I'll give you the short story. You can read the paragraph, but I'll give you the short story. I'll use the figure right here. Figure 64-4. You can see the figure? No? Can you see it, Miss Lakla? Bettina, can you see it? Okay. So what you're looking at is the neuromuscular junction. This is your neuron, nerve ending. Okay. Okay, so this is the muscle end plate, and these are your nerves. So this is a skeletal muscle disorder, autoimmune. Now, how our muscles are stimulated is this. So this is the nerve that will stimulate the muscle. So therefore, can a muscle move without nerve stimulation? No. So that's why spinal cord injury patients, is there anything wrong with their muscles? No, but because of the spinal cord injury, there's no more signals getting to the muscles, so therefore the muscles became useless. Yeah? Okay. So again, in order for muscles to contract, there has to be nerve stimulation. And this is how nerve stimulation goes. So this is the muscle cell, and this is the nerve that's supposed to stimulate the muscle. Now, muscle movement, oh no, sorry, muscle stimulation is made possible by acetylcholine. So with acetylcholine, it allows for muscles to contract. And another neurotransmitter, of course, is dopamine. Dopamine allows you to control those muscle movements. Yeah. Okay, but let's just stick with acetylcholine and the acetylcholine receptors. Okay. So how muscles contract is it has to be stimulated. So this is the nerve. Acetylcholine travels through from one nerve to another. Acetylcholine has to be received by acetylcholine receptors here. There has to be equal number of acetylcholine molecules and acetylcholine receptors. If this balance is normal, meaning same number of acetylcholine molecules, same number of acetylcholine receptors, muscles will move. So you can move, you can do whatever you want. Okay? Muscles will contract. The problem in myasthenia gravis is it's an autoimmune disorder which attacked and destroyed some of the acetylcholine receptors. It did not destroy the muscle. What did it destroy? What did the autoantibodies destroy? The acetylcholine receptors. So there's no problem with acetylcholine. The problem is with the receptors. Most of them were destroyed. So it's like a backlog. Okay, so it's like a bottleneck. You have enough, you have more than enough acetylcholine, but you don't have enough receptors for them. And moreover, here, when you have acetylcholine, in order for us to stop muscle contraction, because muscle contraction has to stop, yeah? Something is needed to destroy acetylcholine. We call that cholinesterase or anticholinesterase, okay? So therefore, there's acetylcholine and then there's cholinesterase, which will destroy acetylcholine. That way we can stop a muscle contraction. You follow so far? Okay. So, and that's a natural operation. So that's how it's supposed to be. We have acetylcholine and we have cholinesterase, which will destroy acetylcholine. and acetylcholine is received by acetylcholine receptors in the muscle end plate. And again, if all is good, we can do whatever we want. Okay, we can have muscle contraction and we can sustain that muscle contraction. Now, look at what happens to a patient with myasthenia gravis. There's enough acetylcholine, there's enough cholinesterase. What we don't have enough of is what? The receptors. There's not enough receptors from one muscle to another. So therefore, can they sustain a muscle contraction? No. The problem affects anything repetitive. So give me examples of repetitive muscle contraction. What are you doing right now, Judith? Right now. Don't stop. It's okay. What are you doing? You are chewing. Is that something repetitive? Is that repetitive, or do you just chew like this? And then 5 minutes later, you do that? 10 minutes later? We chew consecutively, right? It's a continuous or repetitive muscle contraction. What about me speaking? Is this a continuous muscle contraction of my vocal cords? Yes. What about swallowing? So when I'm having a meal, say I'm eating a bowl of cereal, chewing and swallowing, is that repetitive? Yes. Walking, running, breathing. Yes, these are all repetitive muscle contractions. So which actions are affected here? Respiration, chewing, swallowing, talking, walking, name it. Anything repetitive is affected. So what happens is, it's not like you can't perform it. You can perform it. You can chew, you can swallow, but can you sustain it? Can you sustain it? Meaning, can you finish a lecture? Can you finish a meal? Can you finish getting to where you want to walk? No, because you get tired. You get tired, you cannot sustain the movement. That's the problem in myasthenia gravis. So literally, this word, myasthenia gravis, means grave or severe weakness. Myasthenia is weakness, and gravis is grave or severe. So this is therefore interpreted as severe muscle weakness. It only affects skeletal muscle stuff, right? Early manifestations will be diplopia and ptosis, because blinking your eyes, is that repetitive? Yeah. Are you aware that you blink your eyes how many times a minute? Now you're conscious. You're doing this now. We actually blink our eyes more often than we think. Okay, so that is affected. So the patient therefore has drooping. You look like, who's that dog character? No, Snoopy's not drooping. Who's that dog character? Help me out here. I forgot. Okay, anyway. So you have double vision and drooping of the eyelids. That's usually the most common complaint. And then some patients, of course, can't, like they complain, I've been tired and weak this past few months. I don't understand why, especially around my face. So these are the bulbar. Bulbar muscles are those involved in chewing, swallowing, speaking. Okay, these are the muscles that you use when you chew, swallow, and speak. Bulbar muscles. So they're all around the face and neck. Limbs, respiratory weakness will also be affected. But the earliest again are the bulbar symptoms and the eye symptoms, the drooping of the eyelids and the double vision. In severe cases, what really causes the patients to die, or at least die from complications, is aspiration. So they continue to eat, hoping they can finish, but they don't. They start choking, and then, of course, one of those choking episodes will lead to aspiration pneumonia. So food particles get into your lungs, and then you get an infection, then you get sepsis, then you die. All right, so how do we know you have myasthenia gravis? So let's say you have these symptoms. Doesn't automatically mean, oh, those are symptoms of myasthenia gravis. That's what you have. No, the doctor has to do a test. Okay, so let's look at a scenario first wherein you have not been diagnosed first. So let's say it is Miss Georgian. What's your first name? Tanisha. Okay. So Tanisha has these manifestations here. So she's having eyelid drooping, she's tired, she's having double vision, she can't concentrate in class, she can't study, she can't finish a meal, she gets so tired walking, she has to be resting every few feet, she has to find a bench to sit on. Okay. So she goes to her doctor, hey, what's wrong with me? Okay, so the doctor will do a Tensilon test. Tensilon is T-E-N-S-E, no, sorry, T-E-N-S-I-L-O-N, Tensilon. That is the brand name of edrophonium chloride. Edrophonium chloride is the generic name. The brand name is Tensilon. So the doctor will perform a Tensilon test, IV. What is Tensilon? Edrophonium chloride is a anticholinesterase agent. Remember cholinesterase earlier? Cholinesterase is the enzyme that will destroy acetylcholine. Okay. If we give you edrophonium chloride, which again is a anticholinesterase agent, which will prevent cholinesterase from destroying acetylcholine, what will be the effect? So I have weakness with repetitive muscle movement. If I don't destroy acetylcholine, that means what happens to my acetylcholine levels? It will increase. So let's go back here in the pathophysiology. Since I don't have enough receptors, but I have enough acetylcholine, however, acetylcholine will eventually be destroyed by cholinesterase. What if I give you something to prevent cholinesterase from destroying acetylcholine? That means what will happen to acetylcholine levels? It will increase. Even though I don't have enough receptors, I have enough acetylcholine. So this will actually improve. This will kind of make up for the lack of receptors. So at least, yeah, I don't have receptors, but my acetylcholine will not be destroyed by cholinesterase, making it available longer at the junction. Does that make sense? Okay, so that's the test. So if I have a positive Tensilon test, meaning, look at the description. So I come into my doctor's office. Tanisha comes into her doctor's office, and then the doctor injects edrophonium chloride. 30 seconds after injection, her symptoms improve. Her muscle strength increases. Does that make sense? So therefore, it is a positive Tensilon test. That means, what does she have? Myasthenia gravis. Okay, so that's the first scenario, okay? So Tanisha has never been diagnosed, therefore she's not been taking any treatment for myasthenia gravis. So we gave her a short-acting, so edrophonium chloride is a short-acting anticholinesterase agent. This is an anticholinesterase agent, but because it only has a few seconds of half-life, therefore lasts very short, only for a few seconds. Is this used for treatment? It can't. It can only be used for testing only, diagnostic testing. Are we clear? Okay. So to treat this patient, will she benefit from anticholinesterase agents? Yes, long-acting ones. Okay, we cannot use the short-acting anticholinesterase, which is Tensilon or edrophonium chloride. Does that make sense? We can't use this for treatment. We can use this only for diagnostic testing. Okay, so once we have a positive test, she had a improvement in muscle strength, 30 seconds after injection. So doctor gives her the news. Oh, good news and bad news. Good news is I know what's wrong with you. Bad news is it's myasthenia gravis. All right. Okay. We'll look at atropine later. I can explain atropine better later when we talk about the crisis. Okay, I'll come back to this. We can do other tests, but the most commonly used test is the Tensilon. Okay, so we can skip this paragraph here. Let's talk about the last one. Some patients, not all, okay, only a very small population of those with myasthenia gravis has a thymoma or a tumor in their thymus gland causing the antibody production. Okay, but it's only a very small population, meaning if they do this test and they find that tumor in your thymus, where's the thymus gland? Right here, okay, in the external notch right here, suprasternal notch. So if they see a tumor, they do a CAT scan and say, oh, you have a tumor in your thymus gland. Maybe this is what's causing your myasthenia gravis. So if they take it out, the patient improves. Right? But again, are all myasthenia gravis patients have that problem? No, majority is a autoimmune form. Okay? So only a very small population have that thymoma. Let's go to management now. So we make a diagnosis. What will be prescribed to Tanisha? We will give her anticholinesterase agents. Okay, the options are anticholinesterase medications, immunosuppressive therapy, specifically IVIG or plasma exchange. And of course, as mentioned earlier, thymectomy, okay, or removal of your thymus gland if you have that thymoma, right? Again, there is no cure for myasthenia gravis. Treatments do not stop the production of acetylcholine receptor antibodies. Are we clear? So what is the purpose of all these treatments, therefore? Improving function and reducing the antibodies. That's all we can do. What are they again? The goal of therapy? Improving function so that she can function. She can work as a nurse or whatever she wants to do. She can be a mom. She can be whatever she wants to be, okay, without the symptoms of her condition. Are we clear? No, she can live every day. She can finish a meal. She can talk. Okay, she can work. All right. That's all we can do for myasthenia gravis. Okay, let's start with the first option, which is anticholinesterase medications. So for long-acting, unlike idurfonium, the preferred is pyridostigmine. So almost everybody takes pyridostigmine, although there was a commercial on TV again I saw from myasthenia gravis. I can't remember the name, but there's a new treatment. It's not available in textbooks yet because this textbook is at least 5 years old now. I'd say 5 years old, although the copyright is, I think, 2021. However, they had to write this book, yeah? So even though it was published in 2021, when did they start writing it? 3 years before, all right? So therefore, it won't make it to the textbook until the next edition. Does that make sense? So how does pyridostigmine work? It provides symptomatic relief by inhibiting the breakdown of acetylcholine. So therefore, it stops cholinesterase from destroying acetylcholine, making it available longer at the neuromuscular junction. Does that make sense? Okay. Side effects: diarrhea, abdominal cramps, excessive saliva. Okay. If pyridostigmine doesn't work, then we will use immunosuppressants. Next option. For exacerbations, meaning a flare-up, remember, myasthenia gravis, does it have a cure? So therefore, is it chronic? Yes. If they take pyridostigmine, can they be in remission? Can they be symptom-free? Yes. Can they have flare-ups though? Just like asthma, can they have attacks? Yes, they can have attacks. So if they have attacks, then we will have to use two therapeutic, one of two, okay, not both, one of two therapeutic modalities. One is very expensive, IVIG. What is IVIG? This is IV immunoglobulin. What are immunoglobulins? Antibodies. Okay, they're very expensive, at least $1,500 per gram. The dosing is based on your weight. So if it's, let's say, 1 milligram per kilogram and you weigh 79 kilograms, how much are you paying? Tens of thousands of dollars, right? So you can just imagine the cost associated with this option. Do you understand? Although this is the safest, it's antibody infusion. Again, very, very expensive. An alternative is, let's say, oh, your insurance doesn't cover IVIG. We do, however, cover plasmapheresis. We look at plasmapheresis. There's a section, there's a chart for it. Okay, I'll just describe what is plasmapheresis right here. Page 2101. So what is plasma exchange? Remember dialysis? You remember hemodialysis? Okay, what did we do with hemodialysis? We took out the patient's blood, go into a machine, and what did the dialyzer remove? Waste products, excess electrolytes, excess fluid, yeah? And then return the clean blood to the patient, okay? In plasma exchange, same idea, but because it's plasma exchange, or also what we call plasmapheresis, what is removed as the blood leaves the body and then goes into the machine? No, this is plasma exchange. So what is removed? Plasma. So the patient's blood goes out. So same idea as dialysis. So you need an access site, yeah, AV fistula or dialysis catheter. And we stick you and then go into your blood leaves your body, goes into the machine. The machine will remove your plasma while it's in there, then returns the rest of your body into you. There's two ways to do this. When we say plasma exchange, yeah, we remove your plasma and give you someone else's plasma. So let's say we have a donor, it will be Rebecca. Rebecca's plasma will be given to Tanisha. Why plasma? Why does this therapy work? Why does it work when we remove Tanisha's plasma and give her someone else's plasma? What is in that plasma? No, what is the contents of plasma? Why are we removing her plasma and giving her somebody else's plasma? What's wrong with her plasma? What is the nature of this disorder again? What is myasthenia gravis? It's an autoimmune disorder. Therefore, what's wrong with her? Her antibodies are attacking and destroying her acetylcholine receptor sites. So, where are antibodies found? In the plasma. Are we clear? So we'll take her plasma, give her someone else's plasma. Does that make sense? When is this therapy used again? IVIG or during exacerbations, okay? When she's having an attack, meaning she's decompensating. The treatment she's using is not working, okay? She's weak, she can't breathe, she can't swallow, right? She can't even talk, hardly talk. Her eyes are closed, has no strength whatsoever, severe weakness. She goes to the hospital, we'll do one or both. We don't do two. It's a waste of money. It's either one or the other. Are you clear? So either IVIG or plasma exchange. Okay. Surgical management, again, this is for thymoma only. Again, not all patients with myasthenia gravis have a thymoma. So this option is only available basically, or obviously, for if you have a thymoma. Complications. Okay, so picture Tanisha's life. So we got her diagnosis. Doctor prescribed, okay, here's pyridostigmine, and take this, okay, this many times a day. However, Does she have the same activity as me? Like at my age, am I having the same, my role as Tanisha? Tanisha, are you a mommy? No, you single, available. Elder, and who else here? Benjamin. I have a backup. Yeah? I'm not telling you to leave anybody. Okay, it's in addition to. Okay, all right. Kidding aside, so we have different activities, right? So here, let's say when I go home, I pass out. That's my activity. Do you pass out when you get home? You still have other things to do, yeah? Okay, so therefore, if both of us have myasthenia gravis, will we be taking the same doses, the same frequency throughout the day? No. I have less requirements because I don't have that many activity. I pass out when I get home today. I pass out. See you tomorrow. She, however, she has the strength to, she's younger. She go out maybe dancing or on a date or whatever, right? So she has more energy requirements. So she needs more or less of the anticholinesterase agent, more of the pyridostigmine, whereas me, less. However, if let's say um, she plans a marathon, will she be requiring the same doses as usual? No, she'll be taking more. So the patients here will make adjustments as the more they learn about, the more they take this drug, the more familiar they get with, oh, okay, oh yeah, I noticed the last time it worked if I took this much. Okay, so it's always a trial and error with these patients. Because it's a trial and error, can she miscalculate the dose? Can she end up taking more, meaning too much? Or is it also possible that she'll be taking less? Yes. Either way, it becomes a crisis. Okay, let's talk about the crisis. A myasthenic crisis is an exacerbation caused by not enough here. Crisis may result, meaning something happened to her. Okay, so let's say she got sick. If she gets sick, does she need more or less of the cholinesterase inhibitor? More, okay, because she's fighting an infection, for instance. So she needs more anticholinesterase agents. So in that case, is her current dose enough? No. So therefore, can she go into a crisis? Yes. So if the problem is she's not taking enough dosage of the pyridostigmine, we call that a myasthenic crisis. However, can she also over-medicate? Yes. So the last statement here, a cholinergic crisis can result if she's taking too much. What if she miscalculated and ended up taking too much of the pyridostigmine? So she can have a cholinergic crisis. The problem between the two crises is it's not easy to tell them apart. Both myasthenic and cholinergic crisis have these manifestations here. They share the same manifestations. They are only separated by, let's say, sweating, very few separating, distinguishing symptoms. Okay, so therefore, when she comes into the hospital, we know her history now, yeah? So the first scenario I gave you, was she taking the dose yet, the medication? Not yet. She was still being diagnosed. Remember Tensilon? Okay. So we were using Tensilon test to diagnose her with myasthenia crisis. Myasthenia gravis. Now, fast forward few months, few years later, we found her with these symptoms. She's in respiratory failure already. Okay, she's unconscious. She's unresponsive, breathing very shallow. So comes to the hospital, we intubated her. Now the doctor has to investigate what the doctor knows this is a crisis. Okay, so look at the textbook. The doctor says, oh, she has all the manifestations of myasthenic of a crisis, but the doctor is not aware yet. I don't know if this is cholinergic or myasthenic crisis. So let's find out. They have to do a tensilon test again. Does that make sense? Okay, so let's analyze. Myasthenic crisis, what causes this again? Myasthenic crisis. Not enough, okay? Not enough pyridostigmine. Look at here. Cholinergic crisis is caused by over-medication, okay? All right. So, we don't know what kind of crisis this is. The doctor knows this is a crisis. I'm not sure if this is myasthenic or cholinergic crisis. I have to do a tensilon test. What will happen if it's a myasthenic crisis? Meaning she did not take enough cholinesterase inhibitor. Doctor doesn't know that. The doctor performs a tensilon test. What was the drug again used for tensilon testing? Edrophonium chloride. Was it was it long acting or short acting? Short acting. Okay, so let's go back here. So if it's a myasthenic crisis and she receives a tensilon test using edrophonium chloride, what will happen to Tanisha? What is myasthenic crisis again? Not enough medications. Okay. All right. And then what is edrophonium chloride? What is edrophonium chloride? What is tensilon? It's a short-acting anticholinesterase. So it's like pyridostigmine, but short-acting, lasts only a few seconds. So if, let's say Tanisha was having a myasthenic crisis, when the doctor gives her tensilon, what is expected to happen? Symptoms will improve because what is edrophonium chloride again? It's an anticholinesterase agent. And her crisis is caused by not enough medication. So when the doctor injects it, what's her response going to be? She will improve forever or only for a few seconds? Only for a few seconds, but she has improved. So did it help us diagnose that, this is myasthenic crisis? Okay. Yeah. Okay. What if it's the other problem? What if it's cholinergic crisis? She took too much. We don't know that. Doctor doesn't know that. She comes into the ER, already in respiratory failure. She's intubated. Doctor performs a tensilon test, injects her with edrophonium chloride during a cholinergic crisis, which again is caused by too much medication. So what will happen to Tanisha during that tensilon testing? She could die. Here are the manifestations. So the effects will be, she will have bradycardia, asystole, bronchoconstriction, sweating, and cramping. She could die. But what can be administered if it's a cholinergic crisis? Atropine. You follow? Meaning, let's go back to the first scenario. Before Tanisha was diagnosed, she came in with the symptoms, came to the doctor's office. Doctor suspects, your symptoms base here. Your symptoms look like it's, you have these symptoms here. You look like myasthenia gravis, but I'm not sure. Let's try. So gives her edrophonium chloride. What's the expected result? Symptoms improve. Okay, that was the initial diagnosis. So now, fast forward months later, years later, when she was already taking the medication, she comes in for a crisis. This is not for diagnostic purposes anymore. We know she has myasthenia gravis. We're just trying to find out if it's a myasthenic or a cholinergic crisis. We don't know. So in this type of testing purpose, what should we have available for an emergency? Atropine. During the initial diagnosis, Did we need atropine?
No.
We didn't need it because she wasn't on any medication, correct? Now, if we're trying to investigate and 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 um, and differentiate if it's a myasthenic or a cholinergic crisis, what should we have available? Atropine. Does that make sense? Everybody understand this paragraph now? All righty, let's go to, we did the crisis already. All right, so let's continue the treatment if it is a crisis. So what if we were able to diagnose that, oh, it's a cholinergic versus a myasthenic crisis? Of course, we needed that, right? Because the treatment will be night and day. Yeah? Okay. So if you read the paragraphs, we already know she's intubated because that's what the symptoms were, right? So here's the crisis. She comes in with these. Of course, she can't breathe, right? So she'll be intubated. She hits the ER. That's the first thing we do. Intubate her. Huh? No, she's already has the symptoms. See? She's already in a crisis. Here, respiratory cannot support inhalation. She can't breathe. She's in respiratory failure. So she comes into the ER, intubation. So they'll call RRT, rapid response, and then she'll be intubated. Okay. Now, if you think about it, if she has myasthenic crisis, what do you think, just common sense, what do you think will be part of her treatment? She's not taking enough of the drug. That's why she went into crisis. So in your common sense, what do you think is the treatment to give her the drug? Yeah? Actually, no. The reason is the drug, the cholinesterase inhibitor, actually thickens secretions. So for a while, it's not going to be given to her, okay? Because it will just worsen her condition. So it will be slowly introduced, little by little, okay? But don't expect it to be given at more doses than she was before. Does that make sense? Okay, so on the first day, in fact, we don't give anything to her. She'll just be on a ventilator. Okay, the ventilator will keep her alive. Okay, the ventilator will breathe for her, so she doesn't need the cholinesterase inhibitor right now. Okay, she doesn't need pyridostigmine. In fact, because she can't swallow, pyridostigmine is not available in IV form. Only, and it can't be crushed. Only neostigmine. So there's an IV form called neostigmine. So it's not written on the textbook, but just replace pyridostigmine with neo, N-E-O. Neostigmine is an IV form of cholinesterase inhibitor or anticholinesterase agent. Does that make sense? Okay, so slowly we will give her neostigmine, small doses at a time. We monitor her secretions because we don't want her secretions to be increased and thickened. Now we'll have problems ventilating her, right? Does that make sense? Okay. And then let's go to so here, look at that. Cholinesterase inhibitors are stopped when respiratory failure occurs and are gradually restarted. So instead of giving her cholinesterase inhibitor, what do we do? This is a flare-up. So what did we say? What is used during a flare-up? IVIG or plasma exchange. Okay? All right. So what if it's cholinergic crisis? What do you think is the treatment? Of course, makes sense. Do we give her any more pyridostigmine? No more. Okay? Any question on myasthenia gravis? The rest here under nursing management are teaching, especially on medication, education on how to use the medication, what are signs and symptoms to report. Okay, obviously signs of a crisis, and what to do when they get sick. Because what's the common trigger of myasthenia gravis? Myasthenic crisis? What's usually what caused them to be taking not enough? What does this say? The most common precipitator is they got sick. Okay, they got sick. Could be COVID, could be flu. right? Something happened to the patient that caused their usual dose to be not enough. Pregnancy is mentioned here. So she had surgery or pregnancy or medications that exacerbate myasthenia gravis. Right? Any question? Please read the rest because these are the, oh, sorry, I still have the plasmapheresis to discuss. All right, so I'm trying to find it. Okay, 896. Okay, page 896, table 28-3. Okay, let me just explain what is plasmapheresis. So to help you remember, let's discuss what is in plasma. What is inside it? What does it contain? Antibodies, what else? Now, this is the liquid portion of your blood. So let me describe plasma. So if I donate blood, or let's say you get a blood sample from me, okay, one test tube of blood, a big test tube. When they spin it in a centrifuge machine, what happens to the blood sample? It's separated, yeah? So the blood will be in the bottom of the tube and the yellow part is on top, yeah? So that's the plasma, the yellow part. It becomes suspended on top. So all the cells, the blood cells, white blood cells, platelets, red blood cells are in the bottom of the tube and the plasma is on top. So what is inside that yellow portion? It's mostly water, 70% water. What else is in it? Protein, albumin is in there. Antibodies are in there. No. Electrolytes are down there with the cells. So again, it's mostly water, antibodies, protein, and clotting factors. Okay? What's inside it again? Water, protein, antibodies, clotting factors. Okay. So in the process of plasma exchange, if we remove plasma from Tanisha and then give her somebody else's plasma, during the removal, what could happen to her if we remove water, protein, clotting factors, and antibodies from her? Are all antibodies in her body bad? Are all of them causing her myasthenia gravis symptoms? No. But we're not distinguishing. We're removing everything. So what will happen to Tanisha? She has no antibodies. So what happened to her? It will predispose her to infections. So that's one complication. What else? What else is in there? Protein. So since she now lost protein, what will happen to her fluid balance? And what will happen to her blood pressure? Hypo or hypertension? Hypotension. Okay, so we have so far susceptibility to susceptibility to infection, hypotension. What will happen? We removed water from her. Same thing, okay, hypotension. We removed clotting factors from her. She could have bleeding. Okay, so those are your three most common complications from plasma exchange or plasmapheresis. Understand? What are they again? Hypotension, volume loss, and bleeding. Infection, susceptibility to infection. We clear? Yes. Again, albumin helps hold water. Yeah. Yeah. So lack of albumin will cause edema. Okay. So you'll have, yeah. No, not fluid overload. Third spacing. You'll have edema because not because you're fluid overload, but you're volume depleted, meaning there's a osmotic pressure is low now in your vascular compartment. See, so water will leak out. And could she also, because remember, this is like dialysis, right? She has access to, she has either a fistula or a dialysis catheter. So can she possibly experience the same complications as the dialysis patient? The Steele syndrome, the infection, the sepsis. Yeah, same thing, hypotension. So same exact complications, site-related complications as a hemodialysis patient. And that's it for today. Uh-huh. Usually in the fingers, and it's a late, that's late manifestation. Yeah, swan neck deformity and the ulnar deviation usually results if the patient chooses not to receive treatment, meaning joint damage will continue, then damage the patient's joints.